Starting our EPR journey back in January 2022, before we did actually start, we set a quite ambitious mission. So this implementation, we call it a Big Bang implementation because we changed all our legacy electronic systems. We were not on paper apart from the medical records in the wards. Otherwise, we did have a system called CRRS, which is the clinical result and reporting system. We also had a critical care system. We had maternity, a patient portal in maternity. We had theatre systems. So we didn't go straight from paper to digital. So that was a big change if you think about how all the digital systems have been replaced now in one go. So we wanted EPR to be a transformation rather than just a deployment of technology, and a transformation of the way we work to be able to give us an opportunity to work more joined up as a system. As you know, George Eliot and Swift are starting their journey in our domain from next month. And we want to see the benefits actually happening, which is provide a clinically effective and world-class experience to our patients and staff. But very importantly, we've got a quality management system called a UHCWI. We wanted from the beginning of the project to ensure the quality was instilled throughout. And we spent a lot of time with a lot of workshops and stakeholder engagement to understand what this program meant to people. From day one, we wanted to understand how it could potentially, or how we aspire this program to change how people work and how we deliver care. And we wanted to keep it simple, not having 300 benefits, but actually having some tangible benefits which we can measure, like having a bedside mobile solution that works, the digital dictation, the full visibility of the record, to be able to offer a new patient portal with improved patient interface and experience, easiness of handover, and be able to transfer between units more effectively. Reduction in duplication of testing. That was one of our traditional issues in the trust, but with the creation of care plans, now we are seeing the unnecessary test numbers have gone down. And then we wanted to map it over the next few years. You know, what does it mean for year one? What can we achieve? How can we measure it? And what are the teams that we are going to put together to actually review these things? And then what does it mean in the long term? What can we do with the data? And can we use, for example, the population health management module to look at more system-wide and upstream patient comorbidities, smoking habits, and make an impact that way? Because having all the data in one place, it enables you to do that. So once we defined the vision and we went down to every level of the organization to understand and make people understand what it meant for them, then we started with what is our current state. So what that means is we just broken every single workflow down in a form of a process map exercise. And we use our UHCWI methodology to not just view the process and say, okay, we're going to replicate that in our new system, but actually what waste is there in the process that we want to remove? So what do we want in the future of this process to be? What is the ideal case scenario? So things like sepsis, we broke it down the whole sepsis pathway. We understood where the bottlenecks are and where we want the future to be like. We looked at trauma pathway, we looked at stroke pathway, frailty. So there were about 10 key pathways and complex ones that we looked at. And then the following stage were actually to document the future state, remove the waste, make the workflow efficient. So as we moved into the months of implementation, then we have a process called localization, which is where we say to the vendor, okay, now we know what we want from this workflow. We need to put it down on paper for you so you can take it and design it with us. Okay, so the process of localization. And then once every design of every workflow took place, then a process called validation of the future state. Again, many stakeholders were involved in this. from executives, board level to ward level. Okay. Now, important thing to say is to have a buddy trust in this situation. So we did consult East Lancs, which were live before us, and they were very helpful throughout. Now, EPR governance is a very, very complex, matrix, because as you can see in this slide, this is our initial governance structure when we started the program. So you can see on the top, these are the strategic board level meetings. So EPR program board was chaired by our chief exec. All the chief officers were there. Obviously, the program team, CCIO, CNIO, CIO, and then we had people from NHS England attending for reassurance as well, and our delivery partners. And you can see the blue, the dark blue are actually the program structures. For example, I chair Design Authority. Sid, you came to that a few times. We had clinicians coming from George Eliot and Swift to attend. And that is the meeting where the decisions about building workflows or changing the workflows was made. Okay. So we reported to delivery group and then up to the board for approval. Now, the operational readiness was a very, very important group that all of those groups lasted throughout the go live. And then the transformation group looked more the benefits. And then below that, the light green were the working groups and all the work streams that fed up into design authority, into risk, etc. Now, clinical advisory group on the left-hand side was a really important group because that was the way where the clinical voice was heard and fed back into every structure. The other very important group was the clinical risk review group, and that's where we worked our clinical safety case. Now, at the latest stage of the program, okay, there were more steps in terms of, okay, now we built the system, we have to test it, we have to train people, we have to start getting people prepared for go live and the next steps. So it was more transformational, the latter stage, I would say, with a lot of engagement activities. Something called Start, Stop, Continue. I'm not going to go into detail, but essentially we had to tell people what is going to change in their workflow, what is going to remain, and what is going to have to stop with the new system. Okay, and we had to train 12,000 staff, all of those things in their specific areas. So training was a massive undertaking. It was not one size fit all. It was online, it was practical, it was on the elbow, small groups, every opportunity, every corner in the trust. However, we ended up about 2 weeks before we were supposed to go live in October 2023, and we decided not to do that. Okay. And that was a very brave decision and the right thing to do. Now, how we reached that stage, I'm not going to go into detail, but it was important that we heard the people around the trust who were not feeling confident going live with this. And if the staff were not confident going live with this, then the risk of a clinical hazard or an incident or a harm event is high. So it was important that we got our staff into a better place. Obviously, it was very hard for the team, and not just for the EPR program team, but a lot of people involved. A lot of people wanted to get over the line and we'll fix things, but actually sometimes you just need to pause. Now, we don't know whether you've read this book, but I find this book really fascinating. And he has a number of laws in his book from obviously his experience, but the law that I found very relevant in this case, whilst I was reflecting on my life at that point, was why would this idea fail? So complex innovation, implementation of EPR, why did this idea fail? Okay, so we did a very good postmortem learning exercise after we actually paused this program. But what we didn't do, and that's what the Law 25 says, is better to do a pre-mortem, sit down and say what could go wrong with this program, so we can start looking at preventive measures, which is one of the learning points for us. But let's focus a bit on what went well, because we did go live the second round. What went well is our anchor UHCWI quality methodology. So patient safety, patient-centeredness is at the forefront of our trust, hence why we didn't go live the first time. But that helped us really design the program, refine the areas that didn't work. But in terms of how we built the workflows, we built the workflows with the patient in mind and make sure that it fits the needs of and the demands that we are facing at present. And hence why we spend a lot of time on the localization, on the current state and future state, as I explained before. Employee engagement was essential. You will see a bit later how many people were involved, clinicians, but also operational management, administrators, patients, patient forums, etc. It's a whole change approach, whole system approach. One of the good things that we did is collaboration with Warwick Business School, and UHCW has a long-standing collaboration and runs leadership programs, but we spent one of the leadership programs talking about EPR and change, and we spent 2 days with our divisional directors and professors at medical school just to make sense of what change means, what it meant for everybody. And we formulated like a 90, 60, 30-day plan before the go live. And really that brought people together for the common purpose of getting this right. The other thing that we did well, I think, is the clinical risk management. So from the beginning, we had an agency clinical safety officer, I have to say, but she was very, very good. But we managed to advocate, and we now have our own clinical safety officer who is a consultant in the trust. And it's a huge benefit for every other digital program that we do. But essentially, clinical safety played in every work stream and every workshop. And our mantra in the program was, we have to be clinically, operationally, technically safe to go live. Okay, so I cannot overstate the role of the clinical safety officer enough. In terms of building a team, I think Sid could probably talk into that, because I know he's very passionate, but the important thing is there was executive sponsorship of the program. That is key, okay? But there was also bottom-up leadership. So my role was 60% of the time. I'm an oncologist the rest of the time, but I had a team with 2 deputy CCIOs. I had a full-time junior doctor with me, and I managed to recruit consultant digital leads from every division. And at some point, I had around 50 PAs of a consultant time, all backfilled, to help us build the workflows. And CNIO, exactly the same. She has actually a more developed team because her digital matrons are all full-time, and also her AHP team. We have a clinical research information officer as well, and we still got multiple super users who help us with the stabilization. The important aspect is great leadership from pharmacy, because obviously the electronic prescribing system is one of the major benefits. And then communication and engagement, again, is something that I cannot state enough, and there is never enough communication. So there were different ways we and still communicate with our internal staff, but also primary care, understanding what the challenges are now post-go live. How can we work together to make the integrated care records better, to be able to have that interoperability between system partners. But failure was there. We learned failure is important if you want to succeed. And if you go into the theory around projects like this, I mean, the scope is usually quite huge. We were one of the biggest scoped programs in the UK for Cerner. There was a lot of data migration. There was a lot of interfaces because we have kept certain specialist systems such as oncology, renal medicine, ophthalmology. So lots of interfacing work, lots of device integration, new hardware for the expanding community team that we now have. A lot of transformation requirements, actually a lot of the elbow training, sitting down with people, solving problems in clinic. We still got a very good digital clinical team with us that go around and support colleagues. And of course, not to mention the data quality. There is always data quality issues post-go live. We are now getting on top of things, and so very, very complex. So why innovation in healthcare is so hard? Well, first of all, to mention that there are so many stakeholders involved, always competing interests. There is a lot of regulation at the same time, and NHS England brings new guidance all the time. So the things that in 2022 knew they are the case, in 2023 they changed. So that introduced a new risk because we couldn't rebuild the system. So all of those things, healthcare is a very dynamic environment. And of course, this model, which I used in my PhD as well, when I looked into innovation and leadership, is the NAS model. So it looks at the barriers to innovation and to adoption. And obviously we can see them in a day-to-day now, from individuals not wanting to use the system to the organization not being trained enough, or the system and the interoperability issues. So micro level, meso level, macro level. So lots of complex stuff to consider. But the more important thing for me, what I've learned is I came into contact with so many different people I've never worked with, ICT, data analysts, architects, and I think that's the biggest gain from this program. These programs are really, really social, and we need to get the people element right in order to succeed, and the engagement right. We had a good buddy trust, so learning from other organizations is extremely key. But the adoption post-go live makes all the difference. It's the data that you input in so you can get the data out. So if any of the trusts you're working in are planning to implement an EPR, I would say the 5 key things for me is to have a bold vision, know why you're doing it, invest in leadership teams, what's in it for people, think about the enablers, but also the barriers and what could go wrong, and trying to proactively mitigate that so that you don't fail or pause like we did. So a bit of where we are at the moment. So a bit of simpler structure, as you can see. So we are undergoing what we call a stabilization period, whereby, we are bending our learning, we are bending our training. Theatres, outpatients, inpatients, these are the 3 focused areas, and then we've got the diagnostics. So we've got a very mature system of people raising datexes if they happen, they're raising tickets in ICT that we resolve. We prioritize the changes we need to make so that we, as a trust, the performance and the delivery comes back to the same level as before. But swiftly, we will be moving into optimization phase, which is more the refining the program, actually making changes, introducing AI, all these exciting things that excite people at the clinical and operational level. But it's all very exciting, especially, excuse me, with George Eliot and Swift coming along. It's going to be another 2 years of intense working together and making our system more digitally mature.